just hitting record. So thank you so much for that. So it's my pleasure to introduce our last clinical specialist. So our focus this year has really been on the second half of the semester, a little bit less research intensive, although you could argue that you never really get away from any type of research when you're in academia. And to make it a little bit more of a clinically focused course this year. So we've heard from anesthesiologists, we've heard from individuals who are involved in emergency medicine, and now we get to hear from an anatomical pathologist where we get to hear a little bit about some of the systems we've already heard about. So I'm going to welcome our last clinical guest speaker to HMB 422, and I'll welcome you on behalf of the class, who is all muted, but I'm sure they're clapping with me on the inside. So thanks so much for joining us today, Dr. Gershon. And if you could tell us a little bit about your background and a little bit about what you are doing during the pandemic.
Yeah, sure. Thank you for that nice introduction and all the applause. I'm sure people were clapping at home. um, First of all, are you guys able to see my screen right now? Like if I make that full screen, do you see like a full screen title slide? Just if someone could confirm, I guess, in the chat or anything once you see it. In the meanwhile, like Dr. Ju said, I'm Ariel Gershon. I have a bachelor's from U of T. I did like biochemistry and pathobiology. And now I went to medical school at Western, and now I'm back at Toronto doing my residency in anatomic pathology. But we'll talk about like what that is exactly, and this kind of talk is to teach you around like that kind of world. And like the title of the talk is Journey of Images in Clinical Heart and Lung Pathology. So really, like since the pandemic, like, I'm in training to like become a specialist in anatomic pathology. So the clinical work has gone through stages of like slowing down, and at one point the operating rooms weren't working at like the height of the pandemic, and now things are they're back to like a new normal, I would say. And then now and then there's like outbreaks in different hospitals, which is kind of an unfortunate thing, but that's basically what I'm doing during the pandemic, is like going to work every day and working on becoming a specialist. And that takes 5 years, and I'm in my second year. So I guess we can get into it. If you guys want to talk anytime, this is going to be like a fun interactive thing. That's one of my goals here. And then the outline for the talk is going to be like this. While I'm talking about this, do you guys want to write like where you're coming from in the chat? Like where are you zooming from, and I don't know, a cool fact. And then I'll just read the chat at some point. So the outline is going to be a bunch of cases, and then it's going to be part 2 is really short, is going to be like what a career in medicine is like, and then how in general it goes. And my goal for you is to be able to answer like what clinical medicine is, who is involved, and like all the different parts that go into a patient's care. And also, I think it's important for you as biomedical science students to understand this, even if you like don't want to become a physician. I think if you do research in anything related to health, you should understand how these patients present and like what doctors think about these patients and how they interact with their healthcare. These are the big ideas, and we're going to explain all of these things at some point throughout the talk. So we will come back to all this. But big idea is that medicine and science are related concepts, related fields, but they are quite different if you think about how we structure our thinking around them. We're going to talk about the idea of a case. We're going to talk about the idea of test results that we use in clinical practice. And we're going to talk about different specialties and different kinds of physician that work with a patient. There's this little graphic here, which is like a little cute doctor thing. And every time you see it, it'll signal to you that there's actually a different physician involved. And then maybe we'll talk about like what they all do. And then this is really the core idea. Like this is medical reasoning in a nutshell. We have history, we have a physical exam, we get a differential diagnosis, we get an investigation, and then a diagnosis, and then that gives us a treatment and a prognosis. So this is like actually, if you didn't understand anything of what I just said, that's fine. We're going to go through this, but just this concept is like a framework we apply to every patient we see. And then we're going to have a few diseases. Like we're going to bring up a few cases that'll be fun to learn about, and hopefully there's some overlap and some familiarity that you would have seen in your other talks. But that's that. Let's get into it. Okay. Cool. Lots of people. Maple, Toronto, Toronto-ish. It's all Toronto. Okay, awesome. So we've got a case one, and I should also say, like always, I'm going to ask a lot of questions from you guys. I don't like expect you to know anything. It's not to like quiz you. It's more for just like interaction and fun, and try to like get as much as possible out of these cases here. So we've got a motorcycle picture there. Okay, so this is case one. So when we talk about a case, we usually present it with like, what is the person coming here for? This is a 45-year-old gentleman with chest pain. So you ask the patient, like, what happened? We're going to imagine that we're the emergency room doctor. What happened leading up to the chest pain? Let's say we asked them that question. We said, I was going for my daily run in the morning in the park, and I had my earphones in, and I guess my path didn't agree with the biker, and then we didn't notice where we were both going. He hit me head on, and then his head was hurt pretty much, is what the patient will say. The patient has a pretty bad headache and also has pretty bad chest pain and feeling trouble breathing. My friends were worried about me, so an ambulance was called. So then we would ask, like, what other medical conditions does this patient have? This is a patient takes insulin for type 1 diabetes, but otherwise no other health conditions. Okay, so we have that. And then when you're looking at the patient, he looks uncomfortable, and then we took some vital signs here. Blood pressure decreased. Okay, so let's kind of break down the first part, which is called the history. So the history is the story or anything that the patient tells the doctor. And so really it's like an interview, and it can take 5 minutes in some cases. It can take like an hour to figure out the whole story related to the illness. Over here, I've rewritten it and like kind of just picked out the important bits. And like he was running, there was trauma, and then some chest pain and trouble breathing. That's like maybe the most important thing of what he said. And then physicians have a way of writing down like notes that are clear to them and maybe clear to other physicians to like communicate quickly. So I would say HPI is history of presenting illness. So we're talking about this one specific illness, this chest pain, this new symptom. There was trauma. It was pedestrian versus motor vehicle. We got a severe headache. He lives at home with a wife and 2 kids, smoker of 25 years. I think I made a mistake and didn't write the details about the chest pain here, but that's okay. We would gather all this information. PMH is past medical history, other historical conditions that the patient has. But this is like gathering information. So given the information we have, we do this really, really important step. It's called differential diagnosis, but we're going to skip it in this one. We'll talk about it more in the later one. And then, so we've moved on from the history. Now we're in physical examination. So physical examination is anything that you observe or see in a patient, or if you like do a maneuver on a patient, or like touch the patient in a certain way to like test something physically. That's called the physical examination. And you could see this is an example of physical examination. You can look generally, the patient looks kind of disheveled. He's lying down. Take vital signs. These are important parts of the physical exam, and like they change. Like if these are abnormal in any way, like we have to pay attention to them. So there's temperature, there's pulse rate, that's your heart rate. there's blood pressure, and then there's respiration rate. And then you can look at any system in the body. You can look at the head, and we see some abrasions. You can look at the neck. Is there any instability, any pain in the neck, any rashes? You can listen to the lungs and the heart and the abdomen and the extremities. Okay, so this is like a whole thing that it's a process basically you go through. And so for our patient, these are the patient's physical exam. We can see if we just look at the vitals, the temperature is normal, the pulse rate is elevated. Anything above 100 is elevated. We call that tachycardia, which means like a fast heart rate, but you could just say elevated heart rate. Blood pressure is a little bit up, and then the respirate rate is high. So the patient's breathing quite fast. The lungs, so there's many different ways we can examine the lungs. We can feel the chest. Is there any tenderness there? We can listen to the chest, listen for the lungs. We actually hear good air entry on one side, but decreased sounds on the other side. So we would listen and then not hear it on one side. And then we're also, what I'm showing you here is that we have, the physician is feeling for the trachea, which is like the main windpipe that goes from the mouth to the lungs. And it's actually deviated to one side, it's deviated to the right. Okay, so that was the physical exam. And then there's differential diagnosis is also important here, but we're going to skip it. This is moving straight to an investigation. So does anybody know what I'm showing you here? You guys feel free to like unmute and talk if you feel comfortable. I'm asking you like what kind of image I'm showing you, and then also like what is wrong with it. But really, you can answer whatever part you like. I'm also opening the chat to see if anybody has written things. Cool, X-ray. Yeah, totally. So this is an X-ray. Cool, awesome. So Shannon says collapsed lung. Fanar says fluid in the lungs. And Jeanette also. Do you guys want to talk through like where you see this finding? There's also an option to annotate. So I think you guys can see that. You guys can like draw arrows or whatever. And I think.
Sorry, it's Fanar.
Oh yeah, hi.
I think when there's a lot of light areas, it means that there's a lot of fluid buildup, especially over here, like this area.
Oh, cool, cool.
I could
awesome.
be wrong, but I don't know.
Awesome. That's really good. That's a really good observation. So you're saying that it looks very white here. And I agree with you. It does look white there. Can we orient the image, I guess? That's probably a good place to start. So what is this structure in red? It's repeating.
The ribs?
Yeah, these are ribs. And these are, I heard some of you guys are studying for anatomy. Why not? Let's do it. So what is the line that I've drawn like across there? I'm trying to just move this stuff around. Yeah, there we go. There's another one there. These are clavicles. This over here is actually the heart. And these are the diaphragms down here. Cool. And also like this over here is the scapula. It's kind of hard to see. It's not really designed to look at the scapula to study. But okay, so, and this is actually important. This is the right side of the patient. So we have a marker. This is like a little piece of metal or something that says R on it. The patient's like standing up and you're kind of like looking at the patient, but you can see through them. So this is exactly right. This is an X-ray. And I really like what you said, Fanar, about the white, seeing that it's white, first of all, before saying that it's blood. It's actually not, it's not blood, that's not the right answer, but the idea is we have information here based on the color that we're seeing. Is it very black or very white? So the whitest things on this image are what? Bones, I would say. Like this rib is like very white and the scapula is very white. So the denser something is, the more white it is. And if there was metal, and I think this marker here is actually metal, it's very, very white. Okay. And then the darkest thing on this image is if we look outside the patient. So if you look at this like black sliver here, this isn't outside of the patient. This is just like the X-ray beam did not pass through the patient there. This is like the patient's skin, and then that's outside. So that's the least dense thing. So that's air. And normally our lungs are filled with air. I would say actually, so this side is actually normal. This is a mostly normal side. The side that you said is very white. It is more white, but what is it more white from? Oops. I'm going to open up the chart. Oh, awesome. People have been saying the answers and I haven't been seeing. Okay, so ribs, clavicle, awesome. So the right side, I'm just going to draw as I'm talking on this. The right lung is way darker than the left lung. And I'm saying this is normal. So why is this one more white? Does anybody want to guess like what? The trachea that was deviated. What do you mean by that, Christine? How does that explain this? And I'll draw on the trachea since you mentioned the trachea, which is really good. This is hard to see. You kind of have to see a bunch of these. This is part of like training in medical school, is to talk about this a little bit. So, oops. I would say it's bulging out this way. Yeah. So yeah, we can actually see the trachea here. That's right. I like what you said. So you're saying that it would show up on this study. Cool. But the study is showing us a bigger problem, and it's kind of tricky. So I'll just share it. There's actually too much air here. Remember we said air is black. There's too much air. Actually, I'm going to draw in green. There's this white line here, which is just not normal. It's very crisp, right? And here on this side, if you look at these like branching little things, that's the like pulmonary vasculature, little arteries and veins. This is part of the normal lung. And actually they go all the way if you look very closely. So that's just like normal lung parenchyma, normal lung like tissue. Over here, they're absent. So this green line that I just drew is actually collapsed lung. The lung is totally collapsed down. And this is now full of air instead of being full of lung. Like there's no lung there. Does anybody know what this is called? Before I move on, and yeah, awesome, pneumothorax. That's very good. So I put this up here. This is like the job of like interpreting this image is a different physician sometimes than the emergency physician. The emergency room people do interpret it and act on it, but also there's radiologists who do it. So there we have two physicians so far. So this is pneumothorax, and it's traumatic because he had a history of trauma. He probably like he has some kind of trauma to explain this pneumothorax. So what is pneumothorax? We're going to explain. You might have heard about this in your physiology class or anatomy before. So this normal expanded lung, it's on our left side. There's two layers that separate the lung from the chest wall. There's like pleura. And there's two layers. There's like visceral pleura and parietal pleura, and there's a pleural space. If you remember from physiology, that's like a negative space, or it's negative pressure. So its job, there's a little bit of fluid there. It's like lubricates the lung as it moves against the chest wall. And then if you poked a hole and there was a communication from the outside to this pleural space, air would rush in. And then the problem with this is that the lung collapses down, and actually the trachea here is shifted over. It can actually compress the heart, and if you press on the heart, it doesn't work anymore. So that's like a dangerous thing, and so that it can be fatal for that reason. We can also think like, what are the causes of pneumothorax? There's what we had here was traumatic, but there's other reasons to have it. Like, is there a background lung disease, like emphysema, interstitial lung disease, and then something happens, and then there's rupture of the lung, and then there's air in the lung space now. You can also have spontaneous primary ones for other reasons, but there's many different causes of pneumothorax, but this was a traumatic pneumothorax. And then here's another example. On the other side, you can see this is very, very white, which usually is normal, but actually there's no lung markings on it. And then the heart used to be here, but now the heart is here. So actually the whole thing's being pulled over. Trachea is like the trachea is like in black because there's air inside the trachea. It's a little bit less dense. You can see it's pushed way over this way. And so, okay, so we have a diagnosis. How do we treat it? So all the time in medicine, like the way you start a diagnosis, or the way you start a treatment is first you have to have a solid diagnosis. And so the treatment for this is needle thoracostomy, which means you take a needle and you stick it in the patient's chest, and then the air will come out and the patient will be able to breathe better. It's like kind of an amazing thing. And then you can also place a chest tube. You can place a tube into the pleural space and then just suck the air out. This patient was admitted after they got this diagnosis. They put in a chest tube. And the people who put the chest tube in were thoracic surgeons, for what that's worth. So here we have another kind of role. So that's like a surgeon who deals with the thorax, like that's what the name suggests. And then they would be able to put a tube inside and then drain out all the air and then make sure that the patient is doing well. It's kind of amazing because like you wouldn't think that somebody who is coming with chest pain, what they need is like a poke to the chest with a sharp thing. That sounds like very unintuitive, but in this case, that's what it was. Cool. So let's talk about diagnosis in general. So diagnosis means dia, which means through. This is like the root of the word. And then gnosis means to know. And for example, agnostic is like a word you might have heard of. It's like, I don't know, or something like that. The definition that we use in medical reasoning is to know a disease by its symptoms and signs. So when you make a diagnosis, you're labeling a patient or identifying a disease in a patient. What's the difference between a symptom and a sign? I'll just tell you. So a sign is what you see as a medical observer. So you see the trachea is deviated. A symptom is what the patient reports to you. So the patient had chest pain as a symptom, but they didn't have tracheal as a symptom because they didn't come to the doctor saying, oh, my trachea is deviated. So that's the difference between a sign and a symptom. And then here's like the big idea again. So we have history, we have physical exam, an investigation, then we end up with a diagnosis. So we were able to plot it out in this one case. Okay, are there any questions about this first case before we move on to case 2? I will pause for a sec. Okay, anytime you guys have questions, you can put it in the chat. Here we have an 86-year-old with chest pain. She's coming to the family medicine clinic. This is a different kind of physician because she's not feeling so well at home. She has chest pain. She has a previous history of high blood pressure, hypertension, dyslipidemia, type 2 diabetes. Over 20 years ago, she had breast cancer treated with chemotherapy, and she had a right mastectomy. It was 20 years ago. Now she's got new chest pain. So just over a week ago, she started feeling tired, nausea, vomiting. She has chest pain and fatigue right now, and she also has a cough. So let's say we do a physical exam, and these are the vitals here. The thing that's abnormal is she does have a fever, 39.5 and her blood pressure, her heart rate is up at 110. Everything else is normal. Okay, so we don't need to go so much into it. This is the important step that we missed, where we skipped the first case. So what do you think this problem could be? That's my question to you. So you guys can write it out or come in on mic and kind of share. And when I ask you this question, you're coming up with a list of diagnoses that could explain her symptoms. This is called differential diagnosis. And so this is like a mental task or like a mental exercise, which is very important in every clinical practice ever, which is to think like, what are the possible diagnoses? And then we can rank them in order that we think, like what's the most likely diagnosis, or even in other orders, we can say like, what's the most dangerous thing this could be? And so based off of this, you would order tests to rule in and rule out these diseases. Does anybody have any ideas of like what could cause chest pain in this lady? There we go. So chest pain in an 80-year-old. Cool. Angina. So what do you mean by that, Tom? It's a good answer for sure. I'll write that out here. Cool. So we're gonna build on this together. Yeah, sure. I mean, it seems like, so angina can cause chest pain. Do you know what angina is? Like what for, I guess, other people who maybe not know, it sounds like you know. I like what you said, pneumonia is very good. So I'll write that down. Can you guys see my text when I write? Just writing on the slide. Awesome, cool, good. Cool. This is like a very great list already. So like we basically have anything that can cause chest pain, we want to put on this list. And that's like a valid part of the differential diagnosis. The things that don't belong on this list are like, I don't know, like knee trauma or something, like just something totally unrelated. Doesn't cause chest pain. We don't want it on this list. Yeah, awesome. Heart attack. We'll put that in. Heart attack. Okay, so we've got a really great list here. I'm going to show you like another way of organizing this kind of thing. We're going to go to the next one here. So this is like one way that I learned in medical school of organizing around chest pain. First, let me delete this text. But you can think about like the patient has pain in their chest. What lives in the chest anatomically? And so cool. Okay, so we've got the chest wall, the musculoskeletal, like the skin, and the bones and the muscles of the chest wall. If any of those have a disease in them that is painful, then you can have chest pain. There's the lungs, there's the heart, there's the vessels in the chest, and there's the GI system, right? The esophagus and it travels through the chest as well. And there's other reasons to have chest pain that are not anatomically. So like this is a very broad differential, and then we could choose like 2 or 3 diseases for every one of these systems. So if you have inflammation of the costochondritis, this is inflammation of the cartilage, or if you have a muscle sprain in the chest, you can have chest pain. Pulmonary, there's pneumothorax we saw, pulmonary contusion, pneumonia, for sure. These are all causes of chest pain. Cardiac, we can have angina, we have a heart attack, like you guys have said. The aorta can have diseases in it that are painful, dissection, injury, and then GERD is another. So this is gastroesophageal reflux disease, which it doesn't really matter so much, but it's a cause of pain in the chest, basically, for us. And then people who use cocaine or psychiatric reasons or psychogenic reasons, I should say, like they can get chest pain. So this is like a very anatomically oriented way of building your differential. And differential diagnosis, just in general, like you can build it around whatever you want. You can say, what's the cause of chest pain and fever in an 80-year-old? So if I include and fever, like some of these don't cause fever, so we could just get rid of them. So we have a shorter differential. There's another kind of different. This is what I learned. Yeah, awesome. COVID for sure is a kind of like viral pneumonia for sure could cause chest pain. So this is like an emergency chest pain, which like I've used a few times. Like anytime someone has chest pain, I would really hate to send them home and then I didn't think about a heart attack. That's like one way of thinking about this. Like you need to make sure they don't have a heart attack in some situations. So myocardial infarction is on this list, pneumothorax, pneumonia, pulmonary embolism, that's a clot in the vessels of the lung. And aortic dissection is like a kind of entry to the aorta. The reason these are emergencies is that if you treat them, like if you have them, you need to be treated for them. And if you miss them, like the patient does not do so well. So awesome. So we've ordered this test. We've ordered a bunch of other tests on this lady. So we got some blood work and a bunch of other things, but this is her chest x-ray. Cool. Does anybody want to tell me, like, what do you think? Is there anything abnormal about this chest x-ray that or anything that you want to point out or talk about? Again, I think you can annotate. Yeah, for sure, Jeanette. It's like on the front of people's minds, COVID. But I would say, like, still very important is it's not even on this emergency list, but definitely people are thinking about it, and like it's very relevant for people to know. The lower left side has a lot of tissue. Okay, left lung seems to be darker. Okay, which side is left? I'm asking that just because it's kind of backwards from what some people would assume, which is fine. That's just the way it is. So we have a marker here. Oh. We have a marker here on the left side that says, oh, cool, we have an arrow. Okay, so yeah, we're looking at the patient. We have a marker that's on the left. So lower left side, you think is a lot of tissue. Do you mean here? The left lung is darker. Oh, you mean the right? Okay, awesome. Yeah, that happens a lot. That's okay. Okay, so right. And I think it's easy to see if you like kind of think in symmetry, like this is the midline, this is the trachea. You can see it's like very dark. We go down. We have the heart here, the left lower side. This is the diaphragm. I will actually draw it. And then we have this is like not there on the other side. It's very white. So the question is like, which side is normal? Which one's abnormal? This is actually abnormal, the white stuff. Okay, awesome. So we would describe this as like a consolidation, or instead of there being air, there's something there inside the lung. And I think there is still lung there because you can see some vascular markings or air spaces or whatever down there. Like there's a bunch of air there. So the lung is diseased, but it's there. Anytime you have like white on the chest x-ray, it could be like, is there pus? Is there a tumor? There's something that's filling the air and replacing it. So there could be a tumor there. There could be pus is probably the main kind of thing. So the answer here. Oh, and the important thing to notice is that it's impossible to say what it is with just the chest X-ray. We have to put it in context with the other things that we ordered. So if we looked at her other investigations, we would see she has a high white blood cell count. She has a fever. She has a cough. On her history, on her physical exam, we saw a fever again, and we heard crackles on the auscultation. So when we listened to the chest, so the diagnosis here is a pneumonia, right, middle lobe pneumonia, and based on what we got in the blood, we saw that there was a bacteria growing there. So we gave her antibiotics towards a specific organism that we grew in the blood. So infection can happen anywhere in the body. And it happens because there's bacteria who like grow in certain places, and it's kind of random in this case who it happens to. So she was admitted and then given antibiotics, fluids, and then slowly got better and then just went home. So that's kind of a nice outcome for her. Going back, I see, oh yeah, fibrotic tissue. It could also definitely be fibrotic tissue based on the x-ray. We're gonna pause for a break. I guess the other thing about differential here, so if we look at the history, she had a history of cancer in the past. So cancer can return and it can do a lot of different things. So I should have put in the chest wall here, like, is she having a recurrence of her cancer? That can also be painful, cause of chest pain. So definitely something to think about. You would want to make sure that once her pneumonia gets better, the pain is gone, and then that's how you would follow this patient for sure. Okay. Any questions or time for a break? Let's think. Do you guys want like a little break? A few minutes? Yeah, that's a great question. So Professor Ju asks, who was responsible for the care? So there's like different admitting services in a hospital usually. So this patient would probably go to either internal medicine or respirology, and depending on where the hospital is, like that could be staffed by a physician who has training in internal medicine or extra training in like lung diseases, so respirology. And so it would definitely be something like that. And usually what happens is there's like a team of people who are involved. So like there'll be an admitting service. So let's say this patient is in internal medicine, but then if something in the blood grows very strange, like the infectious organism is like very unusual or they need help managing it, they can consult a infectious diseases team, which is another kind of physician who has a different kind of training and different expertise. So like you could see how even in answering that question, like the patient saw an emergency room doctor, they saw probably their primary care physician because they weren't feeling good, and they went to the family doc, and then they also were going to see like a whole team of internal medicine people who like check up with them every day potentially, and like make changes of like fluids and management changes and like all that kind of stuff. So there's a lot of different people involved for sure. Cool. I think what I'll do is I'll take the next case and then we'll take a little break. Hopefully it'll be around 11. Okay, so case 3, we have a 61-year-old with chest pain, and he has a history of hypertension, diabetes, he has gout and appendicitis 5 years ago. This chest pain, it just started like 5 hours ago. It feels like a crushing pain in the center of his chest. He also has nausea and vomiting, and he feels like he has trouble breathing. He can't get breaths in. He hasn't traveled recently. He smoked for the past 30 years every day when you ask him these questions. So he's in the emergency room department. So on physical examination, All of his vitals are normal, actually. So his rest rate is normal, blood pressure, pulse rate. It's a little high, but it's normal. He looks like quite nervous, a little bit sweaty. And then his neck veins are distended. And that's what we're showing here. So this is a little bit more anatomy. Does anybody know what this is? The structure here? Maybe even the structure. I'll put an arrow on it, just for fun. Ooh. Okay, there's two structures there. So one is a muscle here. Anybody know the name of that muscle? Ooh. Cool. This is like the sternocleidomastoid muscle. It's just a muscle that goes from the mastoid process behind the ear. Cleido means clavicle. This is like the medial clavicle, that's the sternum. And here you can see the clavicle. This is all normal, but then this very dilated vein here, this is the jugular, the internal jugular vein. And that's kind of abnormal. Usually we want it to be a little bit lower. So it's a little bit high up. It's distended, whatever. What is our differential diagnosis? So do you guys want to list off a few reasons for this gentleman's chest pain? Also get on the microphone. Yeah, awesome. Sternocleidomastoid. I'm sure Zoom tried to autocorrect it many times. I guess this time also, like when we build a differential, what do you think is most likely and why? Like, is another thing you can ask yourself, or you can share your thoughts. Okay, so this is like, yeah, awesome. Heart attack. This is another kind of thing about differential diagnosis. This is like the most general differential diagnosis. The acronym I learned in med school was VINDICATE. This is like ways to put things into category. There's no anatomy here. This is just like vascular, infectious, neoplastic. So yeah, awesome. These are like really great ideas here. So for each one of those things, actually like all of those diseases you mentioned can fit in one of these categories. And so if you really don't know what's going on, this is like the teaching in medical school. You can always build a differential and try to find something in a category that explains the pain here. So in a 61-year-old, I put heart attack here and vascular. Pericarditis, I didn't put, but it is infectious, inflammatory. That's very good. Ruptured appendix. So how could a ruptured appendix lead to chest pain? That's my question to you. Remember, everything we have to connect it to the presenting complaint. Awesome. Thrombosis. There is actually a way to get chest pain from the appendix, but it's very rare. But I wonder if you know. And maybe that's why you said it. Venous edema. So what do you mean by venous edema? So I showed you like a distended vein. Thrombosis also, by the way, could fit with pulmonary embolism. It's a similar kind of word. Okay, so we have a chest x-ray. Does anybody want to say something about how you feel about it? Point to anything? Yeah, awesome. Coronary heart disease, fluid pressure in the neck veins. Okay, awesome. So we're going to talk about the neck veins for sure. What do you guys think about this? Cool. I'm going to just draw a few things out. So remember, this is patient's right side. It's the patient's left side. See some bones here. Trachea is midline. We got the heart. Some diaphragms. This is the right hemidiaphragm, left hemidiaphragm. We got the lungs, lung markings. And it looks like it goes all the way. Looks pretty symmetrical. So actually, yeah, okay, vascular on the right is more dilated. Awesome. A lot of air on both sides. This is exactly awesome. So everything you guys said, if we put that, okay, yeah, vascular is kind of prominent on the right. It looks very like a lot of air. Actually, this is completely normal. This is like a normal chest x-ray. I'm showing you this just to say like the people who interpret this and like emergency room doctors, they make actions based on this, and it's based off of interpretation, right? Like this actually looks very similar to some cases of COVID. That's kind of interesting to say, but like you're making an interpretation based off of your experience as an emergency room doctor or as a radiologist. So it's not really objective in the same way that you guys are used to in like science classes where you have like a control or something. You really have to have experience with it. Okay, cool. And so what's the reason it looks prominent? Just the way the vessels are kind of like on top of each other. Doesn't mean there's no disease there. Okay, so, and this is just like an annotated version. This is all the stuff that you know is there based off the anatomy so that you can kind of see. And here we have esophagus kind of goes back there. You can see the spinal processes. Okay, cool. Okay, so the patient had a normal chest x-ray and like basically a normal physical exam, normal vitals. Can we send the patient home? Like, what do you guys think about that? Who would be worried about this patient? Who like feels like reassured by the test that we did? And also, like, what do you think about having a normal chest x-ray? Like, how does that change your idea? Or like in this physical exam that I'm telling you is mostly normal, like, is there something more that you need, or are you happy with the way things are? Yeah, awesome. So like what you both have said, I really like this idea that something is serious. We have a history of hypertension. So the idea is like, so what is the disease that we're looking for? This is actually a very big idea. So, okay, we did an ECG. So this is like, I'm not going to teach you how to interpret this. I think it's just not as interesting or fun. But we put leads on the patient, and then we can read the electrical activity of the heart from the chest. there's like a big abnormality here, and that is like this is elevated, the baseline. And like you may have studied in physiology, like we have a P wave, a QRS, and a T. And if the ST segment is elevated, that tells us that the heart has ischemia. The heart is not getting the blood it needs. And actually, we have that. We have like a big thing right here, which is elevated. So the patient has a heart attack, and it would be like a big mistake to send them home, and we'll talk about why. But definitely, your gut instincts were totally right. Like we shouldn't be reassured by a negative on a test. And over here, the example was like on a chest X-ray, because the chest X-ray probably doesn't show heart attacks very well. That's the idea. Every test that we order has like a sensitivity and a specificity, and there's an appropriate use for it. And so based off of this, I feel good that the patient doesn't have a big bacterial pneumonia or a pneumothorax. I would say that, but I don't feel any differently about his likelihood of a heart attack for sure. Like it doesn't help me rule it in, it doesn't help me rule it out. That's a really important concept. And the idea that you have like a gut feeling, or at least like an impression, that's maybe a nicer way of saying gut feeling. But you have an impression based off of your experience that's different than just ordering a test and getting a positive or a negative. So the diagnosis really comes from a combination of both of these things, but people sometimes misunderstand how important it is to have like a clinical impression, especially if you're not in medical school, if you're just like in the lay public, people think there's a test and then you get an answer. It's not exactly like that. So this is like a very important concept that I wanted to show you here. This is kind of fancy. This is called a Fagan normogram. This is a way of expressing exactly what I was talking about, the clinical impression in kind of numbers. So there's three parts to this. First of all, these are percentages on the sides. These are probabilities. And there's a pre-test probability. So let's estimate if we had a 60-year-old, what's the chance with chest pain? What's the chance that he has a heart attack, just like off the street? I would say like maybe 10%. But then, okay, he has hypertension, like you mentioned, Christine. This is actually a risk factor. We know for heart attacks and coronary artery disease. He's also a smoker. That's another risk factor. The kind of pain that it is, like we didn't go into it, but the kind of crushing central pain sounds like a heart attack. So I would actually put his rating above 20%. And then the question is, when I order a test, it has something called a likelihood ratio. So this is like the property of the test where it's like specifically of like, if the test is positive, then you use this number to help you get to the other side of this thing. So if something has a likelihood ratio of 1, and I would say the chest X-ray for heart attacks has a likelihood ratio basically of 1. We start at 20%, and then we draw a line through 1, and then we end up at the same number. This is like 25%. It's the same number, 25. The numbers are kind of flipped. You should just pay attention to that. However, so if we have some other test that has a very positive likelihood test, this one has 2. If we started at 25, we ended at 40%. So then we could say, after this test, there's a 40% chance the patient has a heart attack. And this is like a very interesting way of thinking about diagnosis. Like people do this all the time. This is an example I got with permission from somebody off Twitter. These are all the physical exam findings that have like a really strong positive likelihood or positive likelihood ratios. This is actually the thing that I showed you. So the patient had very distended neck veins. Really, they didn't have anything else wrong. When somebody has distended neck veins and they're assessed by a physician and they say, okay, this guy has an elevated JVP, jugular venous pressure, they have left ventricular dysfunction. So something in the neck can tell you about the function of the ventricles of the heart, which I think is like a really cool thing. But the number here is 6.4. So like 6.4, it's like up here. So if we started at 20, went to 6, you draw an imaginary line, you end up at like 85%. So anyway, this idea is like really important, but I think for you guys to know about the Fagan normogram is like a nice idea, but it all represents clinical impression, and like you have like a model in your head of like all the different things it could be and what the probability it could be. Okay, so I'm just seeing there's something in the chat. Are these tests used often to determine if other tests need to be done? Yeah, totally. I mean, I think like, I don't know if I completely understood the question, but you can correct me if I'm not answering it, but are these tests? So we order a lot of tests. So an example of a test is like we take blood work and we submit it for chemistry or for culture. We do an ECG, that's a test. Even a physical exam, you can think of it as a test, where it's like you're gonna look at the neck, and if the test is positive, it means the neck veins are distended. And there's a bunch of other things, like if you cross the patient's leg and you raise it, and there's pain in the back, that tells you that's a positive test for disc herniation. That's another example. So that's what a test is. And then sometimes, oh, Fagan normograms, how often are they done? Cool. It's actually not done in real life. By that I mean that like in clinical practice, nobody's writing out a normogram. This, I think, is more of a tool. I guess we could call it academic. Like it's more for people who want to understand how they are thinking about their patients and about their diagnoses. I think people do really use likelihood ratios in practice in some situations. Like some internal medicine doctors who I've worked with like actually talk about it. But actually you can do all of this unconsciously with the right training. And so this is more of a visualization for us to learn about what's going on. Cool. Does that answer your question? Awesome. So here's our diagnosis. So myocardial infarction, and I'm very impressed that you guys got to the answer. That's very awesome. So it's also called a heart attack. The things that support it in the history: this patient's a smoker, hypertension, has diabetes. This is causing atherosclerosis over a long period of time, which is a big risk factor for a heart attack. The chest pain and also the sweatiness is like, these all go towards the diagnosis. And we mentioned this jugular venous pressure was high. Okay. So what do we do once we have this diagnosis? First, we'll talk about like what actually it is. Here's the heart. There's like, it's being fed by, these are called coronary arteries. It's just arteries that feed the heart muscle. And you can imagine the heart needs to have oxygen because it's always working and it's necessary to live. So if I put a blockage here, all of the muscle downstream is not going to get the oxygen it needs, and it starts to get damaged. So there's a few complications of having this happen to you. You get chest pain, but the heart itself can malfunction. There can be an electrical problem called an arrhythmia, where the heart doesn't beat properly anymore. This is like super dangerous. You can get acute heart failure. You can get chronic heart failure. This part of the wall, depending on how long things go on for, can get weak. It can actually rupture. So if the heart ruptures, it's like very not good, you can imagine. But then what can happen is blood can escape, and then it goes into the pericardial space and kind of constricts the heart. There's also an increased chance of future myocardial infarctions once you have one of these. So let's say you're in the emergency department, you order the ECG, and you made this diagnosis using all of the information that you had. The person you would call next is an interventional cardiologist, like they're specializing in treating this kind of problem. And I just wanted to show you what this is like, just real quick for fun, and then we'll go for a break. This is called angiography. So angiography is like you're looking at vessels. You guys able to see this YouTube video, by the way? Okay, awesome. So it's based off x-rays, but you're kind of doing it continuously, and then you're injecting a dye which turns out very black. And these guys are ribs, just so you guys see. The ribs are kind of black and kind of curved there. So it's like the chest X-ray, but kind of inverted, just the way the colors are. And so this is the wire that the cardiologist puts through wherever, like they go through some vessel and they go backwards to go into the heart. And I mean, let's look at this picture here. They access this, they put a little vessel through it, a little like catheter through it, and then they fill it with dye. And then this is called angiography. We're looking at the vessels, and you can actually see as these vessels are there, there's like a beating of the heart, which is kind of cool. And then we're going to see like the anatomy of these blood vessels. Like depending on the kind of physician you are, you need to know all the different branches and all the whatever, like me in pathology and like in anatomical pathology, we also need to know this. And so, and there's the spine. So they're moving like the X-ray machine as we go. But so this is the right coronary artery. Look, there's like a branch here, posterior descending artery. But look at the outline of the vessel is very, like you can see the dye is filling the vessel and it kind of moves around. So that's like a normal coronary angiogram. And then this is like an abnormal one with a treatment for stenting. So this patient, because we suspect so highly that they have a heart attack, they would go to get this done. So they injected the dye. This is the left anterior descending artery. And then it's like very, like it almost looked nicked, or like you can imagine it's very, very tight there. The dye can barely make it through. It does eventually make it through, but this is very narrowed. This is telling us that the artery is blocked. And so, and they also say, how blocked is it? It's like 90% blocked. So the cardiologist would like grade it, say how much. And then this looks like a treatable lesion. So I'm just going to show you how they treat it. So they have a stent, which is like a little tube that just opens the artery up again. They place a wire and they kind of like guide the stent through it. And we kind of see how they do that. And you can see like once they stop injecting the dye, it like goes away. So there was a vessel, still is a vessel there, you just don't see it. Maybe I kind of missed it, but there's they target it through the narrowing, they push it through. And then they expand it to put it in place. And this is like after treatment. The stent is over here. And when they put the dye in, it like fills completely. So the patient would like not have the chest pain, and like they would avoid all these complications, hopefully. And so there's that. Okay. My slides have said we really should go for a break. So let's take 5 minutes or so, so 11:20. And in the meanwhile, you guys are free to like, if you want to post things in the chat, I'll answer them before we get back. And yeah. Okay, cool. So great questions. I hope people are back. So I'm going to stall a bit just so people have time to get back to their computer. But to answer your question, yeah, they can redevelop stents. Permanent is kind of like a strong word for anything in medicine. Anytime something happens, the risk that it happens again is higher. That's like a general thing that happens. But for sure, that it can happen that the stent itself gets blocked off again, and then that's kind of a complicated thing. But for sure, so the patient that, like this patient, once this happens, they end up being followed by either a cardiologist or their primary care doctor, and they have a bunch of things that they do afterwards. Like they take medications, they might change their lifestyle, they might talk about stopping smoking. Those are like the main things that like non-surgical treatments for the heart attack. Awesome. And Tom, yeah, I'm gonna explain all this in part 2, really. But to quickly answer it, yes. So the way it works in Canada is like you get a medical degree, medical doctor degree, MD, and then when you have that, you've finished medical school. You can't practice anything in all of Canada, and I think also the US, without having some kind of certification, which we call residency in Canada. And so that's my specialist training. So I'm doing 5 years on top of the 4 in medical school to specialize in anatomical pathology. That's the name of the discipline. We'll talk about like subspecialty, and like who does emergency medicine and those sort of things. But I hope that answers your question for now. We've got just 2 more cases left, and I think they'll go mostly fast. Okay, so is the recording back on? Are you okay for me to continue?
I think we're good to go. So thank you.
Okay, awesome. Okay, so another chest pain. So there's no surprise here. This is all the same kind of theme. So he's 46. He has a history of hypertension, dyslipidemia, type 2 diabetes. Over the past few months, he's been feeling tired, gradually worsening chest pain, trouble breathing, occasional. He has stools that are deep black. So when he has a bowel movement, it's like very, very black. This happens maybe once a month or so. He has a 20 kilogram, I don't know why it's moving forward, 20 kilograms of weight loss over the past 2 months. No fever, no cough, no nausea or vomiting. He's coming into the family medicine clinic. He's not doing well at home. And he hasn't seen a doctor in a long time. So what do you guys think about this story? Is there anything different that you think is significant here? Like, I'll point out a few things. Like, I think, first of all, his age is different. And we're going to like pretend to think like clinicians a little bit. Like whenever I think of someone's age, it changes things about like what is likely. Like heart attacks don't happen. I mean, they can definitely happen at 46, but the older you are, let's say 60, 80, the kinds of diseases those people get at those ages are slightly different. So I would keep myocardial infarction, MI, on my list, but it's like somewhere in the middle of the list, I would say. It's also not really like a sudden chest pain like the last case. Yeah, weight loss is totally different. I didn't mention it in the last ones, and actually they didn't have any weight loss. This weight loss, tarry stool, another totally different thing. It's been going on for a few months. There's like a word that I'm thinking of if somebody wants to write one word to like explain like the different chest, what's different about this chest pain than previous. Actually, this is exactly like, guess what I'm thinking. But it's like a different category of thing. It's like, and actually we saw another case that was like this, the 86-year-old lady. What do you think the word is? And if we go back, this was all of a sudden, I would call this acute. So the onset was like really right away. And this one, the 86-year-old lady, it was like happening over weeks. We could call that subacute. Yeah, worsening. I think worsening is like a really good idea. The problem is you can have an acute problem that happens like today and then it worsens very quickly. But it has to do with like tempo. It has to do with like how quickly. Awesome. Gradual is a wonderful word. And chronic is like the word that we use for gradual. And progressing is another like nice word. But really chronic is like the vocabulary we would use to describe like something that's not all of a sudden, but more longer term. This is a really good answer, guys. There's also like another word you might hear, subacute, and like just about a week is like maybe subacute. I don't know, that's kind of like a vaguer term, but like the differential diagnosis for acute chest pain and then chronic chest pain are like it's the same principles, but you would think of different things. Okay, so awesome. So we have this idea of chronic versus acute. It seems like a chronic problem. It's been going on for a while, and it's getting worse also, it looks like, because that's why he's come to the doctor. We have a physical exam, normal temperature, normal, not normal heart rate. This is elevated for sure. He has tachycardia. Blood pressure is normal. Respiratory is normal. He looks tired and kind of thin. And you can tell because you've seen this patient before, because if you're the family doctor, you have like a long-term relationship with them. Maybe you saw the patient 10 years ago and you have documents to see what he looked like or remember what it was like meeting him. So when you do a physical exam, you're also will do this maneuver where you look inside the conjunctiva of the eye, so like the red part of the eyelid, the inside part, and you notice that it's pale. Okay, and the heart exam sounds normal. The chest sounds good, like the air entry is normal bilaterally. What do you think this problem could be? So I'm asking for like a differential. You can do anything that's a chest pain. You can think about like chronic kinds of chest pain. We can think about like what else is going on for him. He has hypertension, dyslipidemia. That has to do with heart attacks we were mentioning. So it could be heart attack. He has his other symptoms, weight loss, and then black stools. Does anybody know what black stools is? It's kind of like a buzzword for us in medical school. Like we learn a lot about what different colors of stool mean, but this is like a very specific, like something that's important. Yeah, blood. And it's specifically like, there's like different kinds of way of saying blood in the stool. Something that is called hematopoiesia. I'll write it down. Is like bright red blood, which is a different thing than melena, which is what I wrote. Melena is like black. So this is melena. This is like black stool. And melena is like digested blood. That's why it turns black. It's like the hemoglobin is like red in the blood, but then when it's broken down, it becomes black in the stool. And so this means like it could be like a more proximal part of bleeding, like maybe he's bleeding from his nose or anywhere else along the GI tract or like from the stomach, from the small intestine. But it tends to be more early and not late, not like late in the colon, in the rectum. Anyway, and then weight loss. What do you guys think about weight loss? Have you heard about like what that could mean? Oh, and like blood in the stool, how does that connect to chest pain? I can think of like maybe 3 or 4 different ways that you can end up with chest pain because of blood in the stool. This is like guessing, like this is not an exact thing. So a few things that come to my mind is like, oh yeah, awesome. That's like number 1. That's really cool. Yeah, Shannon. So like you can have an ulcer in the duodenum. That's like the most common place, or in the stomach, and they can bleed. And if they bleed a lot, you can digest that blood and then you get whatever. And the ulcer itself, like the duodenum is like around the diaphragm, that kind of area, but you can have like epigastric, which means like the top of the stomach, or like the bottom of the chest. You can have pain there. Um, you can also have like an ulcer, like an ulcerating GERD or whatever. Like that could be very, like the esophagus can be inflamed, esophagitis can bleed. It's not very common, but that can happen. The other thing is, let's say this patient just lost a lot of blood. Doesn't really matter how. Let's say there's something causing bleeding. The reason the patient has a high heart rate is because maybe he doesn't have enough hemoglobin in his blood. That's called like anemia. I mean, we have some evidence of it. Like he has pale conjunctiva, which is like a way of, for us on the physical exam to think about anemia. Definitely, like we have like a big list of things, and like we would order a lot of tests. We would order a blood test to see where his blood is at, like where his blood levels are. And I'm going to show you this X-ray which we got. What do you guys think about what this is? And I wonder if you guys want to try, there is an annotate button. I think where it'll be. When I'm a participant, usually it's like at the top here, next to like the screen share thing. Awesome, esophageal cancer, that's like a really good idea. Lung mets, awesome, very good. Cool, so these are like really, really good diagnoses. Can you like point to where on the chest x-ray, do you see things that support this or not? Like, cool, Christine. The blobs, very good. Yeah, both sides of the lungs for sure. I'm going to point it out so everyone can see with my own annotations. So, okay, let's orient again. So we have our bones here. There's the trachea. There's the heart. Should have looked like this, right? And then, I mean, this is called the mediastinum, where the trachea and esophagus and whatever, all the soft tissue in the middle. I would say probably it looked like that in the past. And we have all this stuff. Like this is maybe normal lung here, maybe here. The rest of it is like, what is this? It actually looks like a ball of soft tissue. And then another one. I mean, could that be vascular markings? Maybe. And then even the mediastinum is like totally like, what is that? What is there? Here's the hemidiaphragm. And like, it's hard to appreciate this, but in the previous ones, this is called the costophrenic angle, which is like the diaphragm and the chest wall makes this angle. And over here, it's kind of sharp. On the other side, it's pretty blunt. This could be a sign of fluid in the pleural space, whatever. That's a little bit too, that's not that important. The most important stuff is like, what is all this stuff? What's all the stuff that's like in the lung and like looks like it's like all these masses in the lung? And totally like what Janice said, and who else said? Mets. Christine said cancer. Cool. So this is actually what this is. And again, if we're like very clear, very precise with our language, the chest x-ray doesn't make this diagnosis. Really, it's you are taking the findings on the chest x-ray. The findings are there's a dark spot here or a white spot here. Like it's really like that. And then the diagnosis comes from you knowing the whole clinical picture and what you're thinking about. So we have like two things going on. We have like bleeding somewhere, which we said could be cancer somewhere. And then we have this stuff in the lungs, which fits with lung mets. So really in this situation where we're talking about cancer, you need to have like a solid diagnosis that is based on something that's like very solid that everybody can agree on. Like we just interpreted this graph, but like who's to say, I don't know, like is this cancer or is it like a weird pneumonia? And are you sure you want to go through chemotherapy and like big surgery without knowing for sure, let's say. So there's a way of doing that. So this is taking tissue samples. I think I heard one of you, or probably a few, are taking like the histology course. And so this is interpretation based on histology to determine what this is. So we have to go through a thoracic surgeon. So this is a surgery that will happen. They will somehow access this tissue and take a biopsy of it, which means just like take a sample, like a big chunk of tissue that's processed in a certain way, and then it's interpreted by pathologists. And so that's what I'm studying to be. It's about like diagnosing disease based on tissue and histology. Here we have normal lung. If I was being mean, maybe I would quiz you about like all the different parts. Does anybody want to like point out like how do you know it's lung, and like anything that you can, any structures you can point out? This is again mostly for fun, but maybe some of you have the test today on this thing. I will drawing in yellow. A, B. I mean, move my head around, but I think maybe that's C. Any one of these? Yeah, alveolar ducts, sacs. Totally. This is totally normal. So the white, for those of you who don't know a lot about this kind of image, we stain things purple and deeper purple. So eosin, hematoxylin, we have these dyes. And then when we process the tissue, anytime you see white, that's actually like there's nothing on the slide. So this is air, like there was air here. This is probably like a terminal bronchiole, and you can kind of see it branches off. And then we have all these tiny alveolar sacs. So you might have seen a drawing of this before. And then like every one of these dots here, like you see those little purple dots, those are nuclei. I would call B, this thing that I've drawn here is like probably a blood vessel. I think there's smooth muscle around it, and I think that's probably blood in there, but whatever. This is normal lung. And then if we looked at the mass that we just took out of this patient, it looks like this. Actually, if you guys are comfortable and know some histology, like what does this look like to you? Like what, I'm going to circle a few things. First of all, there's a little bit of air, but we're totally replaced by this like thing. Circling like the problem. What kind of tissue does it look like? Yeah, totally. You guys answered correctly. Type 1, type 2 pneumocytes. B was a blood vessel for sure. Fibrous tissue. Okay. Are you in, somebody in histology wants to like tell us like big categories of tissue, like what kind of cells are these? How are they arranged? There's definitely fibrous tissue. I would say like this stuff is the fibrous tissue. The nuclei are very squiggly. And probably collagen, probably fibroblasts. I will just get to it because we're mindful of time. And I want to make sure we can talk about some questions. But this is, I will just convince you, or these are making like little sheets. And you remember like what looks like this in the body, like what kind of sheet of cells? It's like the colon. That might sound like it's coming out of nowhere, but it's like, this actually does kind of look like colon. We have like little vacuoles of mucin in the cells. The way they're arranged, like little pencils, the nuclei, kind of like that makes me think of like a colon thing. And the glands are not normal. They're like touching each other. They're fusing. And it's totally not normal to have colon in the lung. Yeah, so these guys are lymphocytes, I would say. I like what you said there. They're really small, blue nuclei, basically, almost with no cytoplasm. Okay, so we have like colon stuff, and I will tell you that it looks malignant, like it looks like a cancer. And I can tell based off of how things are organized, and like I just know the look of colorectal cancer. So we have colorectal cancer in the lungs. So we actually have a diagnosis that one of you have mentioned before. This is metastatic adenocarcinoma. It's probably colorectal. And so once you have a diagnosis, you can also grade it or stage it. Those are words that you might hear, which is just saying like how severe is it. And we were just talking about that in the heart. Like when you had a heart attack, you can grade the stenosis, which is say, okay, it's 90% stenosis, it's 30% stenosis. It tells people, other clinicians, like how much do we need to treat this, or like what kind of treatment we need to give. This is stage 4, meaning the patient has distant metastases from the colon, wherever it came from in the colon. But because the pathologist saw this, and also we did a bunch of our own tests, like molecular tests, to prove that it came from colon, immunohistochemistry, for example. Like, there's a lot of different things we can do. The patient went on to have, they went to a gastroenterologist, again, a different kind of doctor, and then they did a colonoscopy. So they saw a large ulcerated vesicle mass in the, is that, yeah, I'll see you in a sec. And so they found this thing, and they were able to biopsy the mass, and then also show that there's colorectal cancer there, and it's metastasized, basically. So the treatment for this in general, for cancer in general, is chemotherapy, which is like you give a treatment in the blood, surgery, so you can locally remove or resect something, and then radiation, another thing to like try to hit those cancer cells. This is like a graphic I worked on with a student. Some of you might know her. She's currently an undergrad, but like super talented, like artist. You can see that we have a cancer here, and depending on the size, and this is something that we figure out like together with the surgeon and the radiologist, we figure out the size that we see on the specimen. And then this can determine like what stage it's at. And it depends on size sometimes, and it depends on like what structures it's invaded. Like, does it invade through the serosa? Is it limited to the mucosa, or like does it go? There's all these specifications we use when we talk about colorectal cancer, but any cancer, and then this makes part of the stage. So what's the point of knowing stage? So we said like it tells us about what kind of treatment we can use. So this patient probably is not gonna do so well if we just remove the main tumor alone. Like if we just did that, the patient still has like cancer in his lungs. So that kind of makes sense for us. So like that's why it helps us, but also it helps us with something called prognosis. So prognosis, just to cut the word up, before means pro, and then gnosis, again, we saw to know something, and then it means to know in advance. But in medicine, it also means specifically like, how are we going to predict the future of what this patient's disease could look like? And so it depends on the patient's diagnosis. It can depend on the disease itself, and a bunch of other things. So the reason I brought this up, do you guys like know who this is? If somebody wants to write, or like why I brought this up to here. This is like a pretty sad situation that was really publicized. Yeah, totally. So, I mean, I think it was like a real surprise for people, because I was very young. Like he was 46 at diagnosis, and then I think he was diagnosed at like stage 3, and then he had some treatment, and I don't think anybody really knew, at least publicly, like what was going on. And so this is one way of measuring like how people do with cancer. So the 5-year survival means at 5 years, how many of them are still alive after receiving the best treatment they can. So at stage 1, you can see it's quite good. I mean, relatively speaking, to stage 3 or stage 4. And so this is why diagnosis matters and why the accurate stage kind of matters. I want to make sure that we have enough time. I think I will just skip ahead.
Yeah, that might actually be best. If we can just talk a little bit about your sort of career pathway, and I know some students have some questions about what med school is like, or some other health professions. That would be awesome.
Totally, yeah. So yeah, we'll get into that. Actually, let's just have a quick conclusion. So this is just what we spoke about: history, physical exam, investigations, differential diagnosis. You end up with a diagnosis, and then you end up with a treatment based on the diagnosis. You also have a prognosis based off of that. We talked about like different ways you come to a diagnosis, what clinical reading is like, having different like test reliability. Medicine is like we had to like think about every case on their own. It's not really like science. We have like a randomized controlled experiment and you can like control variables. It's really, you have to like think about every case on its own. And we didn't really talk about even like the personal part of it, where you have to like talk to a patient and explain to them what those percentages mean for them and like what their diagnosis is. We saw a few cases. The last case was pretty cool, but that's okay. So people know what this is, like this flower here. I'm going to talk about like med school admissions. I'm kind of like, so I'm 2 years out of medical school, but then I did this 4 years before that. This is what you need to kind of go to medical school in anywhere in Canada. Like you will most probably write the MCAT, which is like a big standardized test with all these different parts: biology, physics, chemistry. And then they look at your GPA, and there's some kind of interview process. And throughout, you'll like volunteer, you'll research, you'll do some things, and you're trying to the kind of professional that the Royal College of Physicians of Ontario and Canada thinks that physicians are, includes all these different things. So physicians are scholars, health advocates, managers, collaborators, professionals, and they work in these big teams. The way it works for me and like for most people in Ontario is you have 4 years of medical school, which you do after undergrad. Some places, some people do more like a PhD or master's before that. Some people don't even finish their undergrad before going to medical school. It's kind of variable, but most places they do it after bachelor's, which is what I got at U of T. And then once you're done with the medical degree, you aren't actually allowed to practice any kind of medicine. Like by the time you're in 4th year of medical school, you're working on these medical teams and you're like seeing patients on your own, or like you have some kind of responsibility on the team that you're working on. And you basically continue doing that clinical thing for 2 to 5 years afterwards in that program that you're trying to specialize in. So like once you're done medical school, or like at the very end, there's this like matching system, which is very similar to like applying to medical school, really. Like there's letters, there's interviews, they look at your grades a little bit. And depending on what kind of specialty or what kind of thing you want to do, you have a different training after medical school. This is me. I'm like 5 years of pathology. I'm in my 2nd year. And so it's longer than medical school. And then you can also subspecialize or like have more training in a specific area. So right now, like in pathology, anatomical pathology, like I see every body system and like I'm trying to learn what every disease basically looks like under the microscope. And so that's why it takes 5 years. But if you work in some academic hospitals or in some situations, like there are some pathologists who only see one kind of specimen or like one area, and they're like super experts in that area. And if you were going to be an oncologist, that would be 3 years of internal medicine plus 2 years of hematology. Family medicine is 2 years, and then there's an option for more training. And emergency medicine, which you saw a few times, was usually 5 years, but you can also do it through family medicine. So there's all these different kinds of ways of getting into clinical practice. There's a whole other bunch of careers, which I won't talk about too much, but there's other clinical people out there that make this work possible. Like there's nursing, there's physician assistants. These are all like acronyms for them. But if you're interested in any of these, like definitely like reach out to people and like try to see what it's like. It's a similar kind of world and work environment. Like you deal with patients, but you're an important part of like a big team when you're a physician for sure. These are some sources. This is my contact if you want to take it down and like ask any questions. I'm going to check the chat here. Do you still get to practice when you're specializing? How does working differ when you're going through specialization? Yeah, totally. The way it works is like, well, the way it worked like historically, like, I don't know, 100 years ago, is that you just found a physician and then you worked under them like an apprentice, and then you became a physician that way. It's not exactly like that, but residency is all about like learning at the same time as you're practicing. There's different levels to it. Like last year I worked in the emergency department, and I would like see patients on my own and then review with like either a more senior resident or the staff physician, and kind of talk about our plans. And like I would start certain things if I was comfortable doing that. So the main difference is supervision. Like I'm like technically allowed to write prescriptions and nobody needs to look at it, but for like big decisions on patient care, there will be like a physician who is overlooking things until they don't have to, basically. So like there's like a graded system of responsibilities. So you are like working clinically while you're learning. That's what residency is like. And there's also like a bunch of exams. I should also say like it's like $1,000 exams to like get the certification at the end of it, to prove to people that like you're safe and that you are like on par clinically with other colleagues. So yeah, totally. So specialization happens during your residency, and to some extent, like people go into medical school thinking about certain specialties that they want to do, or certain areas they want to practice in. And then like when your whole medical school training, really you're like building an application towards a specialty. So like really year 2, year 3 of medical school, people are like thinking about and like working toward, which was definitely true for me and kind of everybody. Like we got a question, can you switch out of your current specialization? Yeah, I think like yeah, it's kind of it's a tricky thing to do, but you like, and you could think about like all the different stages. Like you can start medical school thinking something and then kind of like decide midway that you don't want to do that thing and do something else. You do have to actually, if you want to do like a different specialty completely, you want to like, you need to like pass the exam, for example, and like retrain. So you probably would add a few years, and like maybe you go back and like redo a residency or like part of it. That's possible. But there's some flexibility there, and really it all depends on like who is certifying and like what the laws are around that. Got a question, did you always know you wanted to be an MD? That's a good question. I think like it was always like kind of an idea for me. Like I went to U of T, and the first thing I heard is that it's impossible to become a doctor day 1 of undergrad. So I mean, it was just something on my mind. And then as you build this application, like as you like write the MCAT, I wrote it after my 2nd year of undergrad. Like it just takes like a long time to like get all the pieces together. So like gradually I like learned more and more about what being a medical doctor is like. And then made the application that way. And I think it's totally fine either way to like really feel like that's what you want to do and then change your mind, or like not sure if that's what you want to do and then like go into it. Like people are successful either way. I think that's like an important thing to hear as an undergrad. Like there's probably a lot of like bad things that you hear in terms of like things that stress you out for no reason. I mean, I remember that when I was a student, but yeah, it's a good question.
Just one other quick question, and I know there's one that Katerina has posted as well. Did you have a backup plan in your fourth year? So just in case med school didn't work out, did you have like another, did you apply to other programs in your final year of study?
Yeah, that is like a very, very important question. And I personally, I had a plan. I think it's hard for people. Sometimes people don't think about their plan, or like they're not told to do one. I think it's always good to have one. For me, my plan was to work a year. I was gonna like, I was doing some MCAT instructor thing as like on the side, and I would try to do that full time or like work in um, like an education related field. That's what I really enjoy doing. I think I encourage people to like have a plan that is something they really enjoy. Um, because like the way it works for med school admissions is like it's very like luck based and numbers based, and if you don't make it, it's like often not your fault. um, so definitely very important to have a plan, and my plan also included like applying to different medical schools at some point. So like there's like international schools, there's US schools, there's like you have to make this decision how much money you want to spend on applications and like how much energy you have for it. But that's all part of the plan. It's like you put that in, like, should I apply this year or next year to the US? So yeah. Sure.
So I know there are other questions, and I really appreciate the fact that all of you are posting these questions. I think the one thing that I've heard a lot about you in the past, and I think that this is still true, Dr. Gershon, is that you are a really great mentor. I know you did that a lot while you were here at U of T, and you continue to mentor students. I know that there are some other questions, and I'm sure right now with all the uncertainty around med school applications or just professional school applications, what does a GPA mean during a pandemic? What if there are no research opportunities? So I think the whole admission process and everything else is kind of up in the air. Would it be okay if students reached out to you at the email address that you provided, maybe if they're looking for some follow-up questions, just for the sake of time, as well as just for mentorship? Like it's really hard to find a mentor right now during the pandemic and COVID-19.
Yeah, totally. I'm very sensitive to like that, and thank you for saying such kind things about me being a good mentor. But I'm totally happy to hear if anybody has any questions. I'm not sure. I know people have to leave and go to other things, but yeah, totally. If you want to email me and we can chat about these questions, like really, really big and important questions, like Katerina and Natasha have posted. But anything, I'm also on Twitter if that's more comfortable for you to like shoot me a message. And like I do mostly like medical stuff on Twitter, but yeah, totally. Do not hesitate to reach out, and I'm here to help as much as I can. It's like a very stressful and novel time for everybody now.
Right. And if I could ask all the students, if you don't mind, I'm going to stop recording. So I'll just make sure that we do that.